as an EMS clinician, when you arrive at the door and recognize the call is for a hip fracture, you don't necessarily think this is a call on which I can have a huge impact. This is a patient where if I take the optimal approach, I can really help this patient. But if I don't, that can also have an impact. And I think that taking away that these are patients who, as you said, Maya, you're going to see them every day. These are patients for whom doing taking a real optimal approach can really impact the trajectory of their care. You have a real opportunity to help these patients.
If empathy is sympathy plus a connection, then compassion is empathy plus action, right? Compassion is an action that we do. Compassion is identifying suffering in another human being and wanting to do something about it. And that's the basis for EMS, right? That is, we go out into the field, we do things for other people. I think that, and if we base our decisions professionally coming from a place of compassion, then we're always doing the right thing for the patient.
So the hard part of this job, of what we do out in the field or in the emergency department taking care of these patients, is realizing there is no perfect option here. Everything we do carries some side effects, but ultimate or potential for those. Ultimately, what is the best path forward? And the consensus, I think, in this group and more broadly, is let's treat pain, particularly acute pain, particularly in vulnerable populations such as geriatric patients with dementia who may not be able to communicate that they would like some pain medicine for their broken hip. And so once we've kind of sat down with the key stakeholders, agency leadership, clinical leadership, and come to terms with that, then it becomes that's the standard. That's what we want to meet. How do we get it done?
What does it really take to deliver truly patient-centered care in EMS? This is the EMS Clinical Brief, where we explore how research, clinical expertise, and patient values guide care, and how quality improvement and culture can shape what's possible. Welcome, everybody, to the second episode of the EMS Clinical Brief, which is an evidence-driven podcast translating the science of emergency medicine into practical decision-making for pre-hospital clinicians. Today's episode is going to focus on pre-hospital pain management, in particular in older adults, and I'm joined by three phenomenal guests. What I'd like to do at the beginning is have each of you just introduce yourself and what is your current professional role. So, Tony, can we start with you?
Sure. Thanks again for having me. I'm Tony Rosen. I'm an emergency physician at Weill Cornell Medicine, New York Presbyterian Hospital in New York City.
Aaron.
My name is Aaron Farney. I'm an emergency medicine and EMS physician at the University of Rochester in Rochester, New York. I work predominantly in the Monroe-Livingston region and also in the southern tier of New York State, providing EMS medical direction.
And last but definitely not least, Kevin.
Thanks. My name is Kevin Gustina. I am the captain of clinical care and training at Parents and Ambulance. So I've been a paramedic for a long time, 12 years, 14 years, something like that. EMT line. And I predominantly also work with Dr. Farney, Dr. Dorsett as, in our region.
So today we're talking about really one aspect of pre-hospital care for older adults. And you could think of this episode either as a subset of talking about pre-hospital pain management as a topic, or you can think of it as a subset of talking about pre-hospital care for older adults. And I really think it's the kind of wonderful overlap of both. So I'm going to start actually asking some questions of Tony, who I got to know, I guess it's about a year ago now when we were connected, basically over our love of like all things taking care of older people in emergency services. And since we're talking about like this one aspect of pre-hospital care for older adults, one thing you didn't include in your introduction is that you actually specialize in the care of older adults within emergency medicine. Can you tell people about what it means to be a geriatric EM physician? Because I think some people are like, isn't that just being an emergency physician, since most of the people we take care of are older?
It's a great question, Maya, and thanks. I'll say I became interested first in geriatric emergency medicine, or specifically in how we can improve care for older adults in the emergency setting when I was a med student. Just as you said, EMS providers and EDs have been caring for a lot of older adults really since their inception. Even though we've been doing this since the beginning, a focus on geriatric emergency medicine, or frankly on optimizing care for this growing population, has really accelerated just in the last 20 years. Before that, EDs were really solely designed to manage acute injuries and illnesses. They're really not designed for heterogeneous, complex older adults with atypical presentations, multiple chronic conditions, frailty, polypharmacy, and cognitive impairment. Optimizing care for these patients has been really hard in the modern ED, given the increased focus on rapid assessment, throughput, early disposition. Despite this, though, and I think this is really important for this podcast, evidence suggests, though, that an ED visit typically preceded by an EMS response, may be a critical opportunity for an older adult. Quality care has the potential to make a dramatic impact on their health, both in managing their acute complaint and potentially identifying modifiable factors to avoid representation or functional decline. So, in answer to your question, specialized fellowship training in geriatric emergency medicine has been created at several institutions, hopefully to develop the next generation of emergency physician leaders in this field. The first of these fellowships was created at Weill Cornell, New York Presbyterian, and my mentor, Michael Stern, who has since retired, was the first fellow. So I completed a 2-year fellowship after my residency in geriatric emergency medicine and have stayed on as faculty. But I'll lastly say that I've always, I think, been interested in pre-hospital care. EMS providers are so important in the continuum of what we would call acute, unscheduled care, particularly for older adults. EMS clinicians are seeing inside the home, which can provide essential information for management in the ED and beyond. In an emergency, EMS folks are the very first clinicians to evaluate a patient, and the interventions that we're going to talk about today can have a huge impact on patient outcomes. A former chief resident at our institution, Billy Hausner, who had gone on to do an EMS fellowship at the Fire Department of New York, he reached out to me to say, Tony, all of that Jerry stuff that you and other folks taught us as residents, it hasn't really reached EMS yet. I think we can help make things better. And I was excited and started working with him, and have subsequently connected to you and to other folks who also see this as an opportunity to improve care for what I believe, and I think we all believe, is a really important population of patients.
I just want to pause and reflect on that a little bit, because there was a lot of information there to think about the evolution of thinking about how do we meet the needs of particular populations that we care for. When we think about geriatrics, even it's the thing that we do every single day, right? They are not, I would say, a special population. They are a core population. I kind of feel the same way when people talk about gynecologic emergencies as a special population when it's 50% of the population. But in emergency department care, we kind of realize that the system was not meeting the needs of these patients we take care of all the time that are really kind of complex compared to some of the problems that we were designed to take care of. And so there was specialty training built and special guidelines. And I work in the one geriatric certified ED in our region, and I love it because I like taking care of older adults. I ended up doing EMS because I thought this is actually how I can change the trajectory of care for older adults. And today there's so many things that we can talk about regarding geriatrics and older adults. And usually when I'm asked to talk about geriatrics and older adults, I talk about falls in older adults as a geriatric syndrome and a complex medical presentation. But specifically today, I want to talk about one aspect of care that we don't tend to single out, which is pre-hospital pain management. And within our own region, we've started doing a regional quality improvement project on pre-hospital pain management to improve this for patients who've been injured. And one of the things that we realized as we started looking at our data is that there is a whole subset that if we could improve pain management for older adults who have severe pain in a safe and effective way, we would actually improve significantly, because of the proportion of patients that we take care of, our regional performance on these measures. But when we talk about pre-hospital pain management, I think, I've heard the words, nobody dies of pain, right? That is this an area that we should be focusing on in pre-hospital care? And while there are national guidelines on pre-hospital pain management, while my EMS services carry as many medications to manage pain as cardiac dysrhythmias, I'm interested specifically for this population of older adults, Tony. Why does acute pain management matter beyond compassion, which is still extraordinarily important?
Totally. And I want to emphasize that I agree that compassion is important. Part of what we do as responders to emergencies is help people. And I think that controlling pain is an important part of that. But I also think that we ought to keep in mind, first, for all patients, that managing pain is one of the most important and frequent things that we do in the emergency department and that our pre-hospital colleagues do as well. I want us to think about this way. Acute pain is not just a symptom. Untreated pain produces physiologic, psychological, and behavioral consequences that can really directly worsen patient outcomes. Severe acute pain triggers the physiologic stress response and activates the sympathetic nervous system. It increases your heart rate, your blood pressure, the myocardial oxygen demand, respiratory effort, and stress hormone release. These changes can be dangerous, maybe less dangerous in a 24-year-old, but for a 78-year-old with underlying cardiac or respiratory conditions or a limited physiologic reserve, these vital sign changes can have a real impact. Also, pain, particularly with chest trauma, can prevent deep breathing, which can lead to hypoxia and hypercapnia. Poor pain control for older adults can lead to delirium, and delirium can be life-threatening. And so I think that from my perspective, what I want us to change the way we think about pain control from this is a nice to have, as you were saying, Maia, to a this is a core and central and critical thing that we do for patients. Also, and again, I want to emphasize, I know we've been talking about this throughout the podcast, but what EMS folks do matter. Early pain management is essential to avoid what we call the pain kindling effect or the wind up effect. Evidence shows, and anecdotal experience that I think we all have certainly confirms, that it's harder to control pain that's been ongoing, increasing, than it is to control it initially. The pain receptors in the body actually can become centrally sensitized. That's something that's been shown in the literature now. And then you're going to require much more pain control downstream. Just like saying an ounce of prevention is worth a pound of cure, an ounce of pre-hospital pain control can prevent the need for multiple large doses of pain medication with the associated side effects in the ED, hospital, and subsequently. This is particularly important and worth keeping in mind because last I checked, transport times can be long, particularly in rural settings and in the urban settings where I work. ED crowding can delay definitive treatment. So the pain control that you're giving a patient may be the only pain control that they're going to get for several hours. Also, and I know you mentioned it, Maia, but I kind of think it's worth mentioning again. The pain control is really the core of humane patient-centered care. And sometimes I think I feel like it's one of the things that we're most lucky to be able to do for others.
I think delirium, sometimes we expect that the patient gets delirious in the emergency department and we kind of blame the environment or being in the hallway and all of those things. But there was I think a really important emergency department study that looked at risk of delirium development in older adults who had hip fractures. And the greatest predictor of whether or not they developed delirium in the hospital stay was their first pain score in the ED. Not how much opioids they received, not all these other things, but what their first pain score was in the ED. And you alluded to it, but I think in EMS very often there's this concept of like the hospital is the closest ALS for pain management. But we all know that we can't unload the patient off our stretcher often, right? With wall times within a reasonable period of time, let alone make sure that the patient gets analgesia before they go to X-ray. And most studies it's greater than 45 minutes where it's looked at in geriatric hip fracture patients. It's greater than 90 minutes for that first analgesic. And so I think saying like, what is the destination to the hospital is not actually the equivalent of the destination to when that patient's pain is initially treated. And so I think that kindling effect that you're talking about really does matter. I'll never forget, not that it was common, but I had a patient who was brought in by EMS, had significantly unmanaged pain from a hip fracture, and she was in the hallway right outside of our provider room and had come back from X-ray and flash pulmonary edema, sudden onset respiratory failure, a SAT of 50. Luckily, she did not get intubated. We were able to like reverse her with BiPAP and nitrates, but it was like hip fracture to the ICU on a nitro drip and like actually significant delay in her operative stability to actually have her hip fracture fixed. And that seems like insane and rare, and it's pretty rare, but if you think about the stress of what her blood pressure was doing, like what her stress was doing on somebody who had baseline systolic dysfunction, the impact of pain had a really bad impact and was super concrete there.
I couldn't agree more. And I feel like we're kind of a hip fracture center of excellence at our place. And the number of times that I see sort of AFib with RVR in the setting of uncontrolled hip fracture related pain, I really do think that these are making physiologic changes, and the kind of dramatic presentation that you're describing. And I'm sorry that you had that case. I don't think it's as uncommon as you think. I think that's more common, and I think that more aggressive pain control in the pre-hospital setting can have a real impact on those downstream poor outcomes. Often EMS folks don't see the delirium. Sometimes the ER folks don't see the delirium. We may have caused it in the ER, but you don't see it until hospital day 1.5. And so we don't think about it as something that's related to the care that we provide. And I think that's really, really important for us to take responsibility that there are things that we can do. There are things that we can do to change this. There are things that we can do to make this less likely. And we need to take on that responsibility and remember that just because we didn't see the patient become delirious doesn't mean that they weren't delirious then when we had them in our care, and also doesn't mean that something that we could have done may have made an impact on that.
The reason I wanted to turn over to Kevin is one of the many reasons. There are many reasons that I hold Kevin in extraordinarily high regard. But I think number one among them is how much he values and talks about compassion. And so I think it's important to talk about these concrete outcomes that really do matter to patients. But I also think that there's value in talking about compassion, how we make patients feel, and like what does that also impact for us. So Kevin, do you want to share with us like how you think about this as a pre-hospital clinician about the value of pre-hospital pain management?
Yeah, thanks. I appreciate the compliment. Yeah, right. Like, I mean, philosophically, I feel that EMS is kind of a blessing in our lives. To lead a noble life, it's right speech and right actions and right job. And this, we're given the ability to practice compassion and get paid for it, right? We get a roof over our head and food on our plates. And what we do every day is like actually get to use that compassion muscle. And so when I think about like the compassion in the sense of EMS, I kind of look at it like I call it the spectrum of human caring. And among the spectrum, the very basic, it goes sympathy, empathy, and compassion, right? Where sympathy is just the starter point for caring about another human being. And sympathy is very much just recognizing distress or suffering in another person. And you can the sympathy is real easy to do. You could do that sitting home on your couch watching YouTube when somebody jumps on a treadmill and biffs their face on the wall, and you can say, "Wow, that sucks," right? Like sympathy is that phrase that sucks, and whether we come into EMS understanding sympathy or not, that's what basic EMS school is recognizing distress in another person, whether it's tripod position or respiratory rate or and currently we're doing a quality improvement project on pain scales in infants, right, and children. And so like the 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 FLAC pain scale is looking at whether this patient is suffering, and sympathy is the entry point, and then empathy is the next step up on the spectrum, where we're not just talking about recognizing it, but actually having like a human connection with somebody, being able to identify with that suffering. It's like sympathy plus connection. And if you could see this in real time, if you're in a room with two people that have had kidney stones and one of them mentions it, like they almost telegraph their pain to each other, and they're both grabbing, going, I remember that, right? Like that's that connection. And it's just understanding suffering in another person, because I'm a human and I've also suffered and I can identify it. But we don't necessarily, I think, and EMS is a big part of this, we don't necessarily need to have had that distress in order to understand how it must feel in another person. Like, for example, I've never felt a sickle cell crisis, and I will never have endometriosis, but I know that it is very painful in other folks. And and that's just like part of the human connection that we have would be our empathy, right? But then if empathy is sympathy plus connection, then then compassion is empathy plus action, right? Compassion is an action that we do. Compassion is identifying suffering in another human being and wanting to do something about it. And that's the basis for EMS, right? That is, we go out into the field, we do things for other people. I think that, and if we base our decisions professionally coming from a place of compassion, then we're always doing the right thing for the patient. And if we look at things like, pain management, I think is a really classic example of this. And I'll borrow a phrase from a friend of ours, Kirby Johnson, who said virtuous intent, right? We don't wake up in the morning and go, I'm going to blow 4 IVs on this 96-year-old, right? Like we want to help people. And we go forth in the world with this compassion mindset. And then, something happens along the way, and there's systemic influences that I think, as part of our quality improvement project is identifying these, because like, a system will get the results it's designed for. And I think whether it's, equipment or guidance or culture or whatever it is, I think people would do the right thing if left to their own devices until you start adding things that they have to do, right? Like and it's not just a bureaucracy, it's not just paperwork. I mean, it can be charting software or your monitor or, a rule at your agency. But I think like the compassion aspect is in every single one of us, or we wouldn't be EMTs. And just being able to turn it loose and unbridle that compassion, I think is, the goal of our quality improvement project. If I can, put a plug out for the Pain Coalition.
Yeah. So I think that's a good transition of how do we build systems that enable people to do the right thing and treat patients. And I'm going to take a moment to talk a little bit about our own system, because really our interest in this came from looking at the data in our own system. The Monroe Livingston EMS system that Aaron and Kevin and I all work in, that is far north in the state that Tony lives in, I think is very high performing in a lot of ways. I actually know we're very high performing in a lot of ways because we track a lot of metrics. We're really good at airway management. We're very safe around pediatric medications. We take actually really good care of non-transported geriatric fall patients and assess them really well, which is pretty unique. And there's so many things that I take really great pride in. But when we looked at our performance on a bunch of national quality measures, when we looked at our performance of do we reduce pain in patients who have been injured, we are not high performing as a region. And to me, that's kind of in stark contrast with everything else. And I say that because I think quality improvement starts with airing your dirty laundry and like realistically acknowledging what your opportunities are. Like if you're going to have spend a bunch of time and energy into fixing something, it should be a great opportunity. And when you're not the high performers, and there are high performers, it means not that you suck, but that there is a great opportunity to change the system, right? Because somebody has achieved it. And I think that we can achieve the same. So we started working on this project. And as I said, when we focused on this, I was trying to kind of get traction on like one population we could glom onto, because I found that there was a lot of barriers to pain management. A lot of things that I think are deeply ingrained culturally of like, does this patient deserve my pain meds? Or is pain really that important to treat? Or I'm interested in both kind of like talking to Aaron and Kevin as people who Aaron is both a medical director and a paramedic in our system, and Kevin is a paramedic in our system, about does that reflect what you have seen clinically?
I can jump in on that. So when I think about why injured patients aren't getting adequate pain treatment, it's multifactorial. It's never just as simple as we're ignoring the pain. Particularly the subset of geriatric patients. What's one of the more common reasons geriatric patients get injured is ground level falls, right? And so most of our geriatric hip fractures aren't skydiving incidents, right? They're trips over cords at home, over thresholds. And when you look at the subset of ground level falls, those are almost all dispatched, at least in the EMD system that most jurisdictions are using, as a BLS call. And so the tone right from the get-go, the structure that EMS is responding in, is that this is a BLS call. And certainly there's a number of BLS pain interventions that we can do to support those patients, ice packs, position of comfort, etc. But at the end of the day, when someone's femur is fractured, those measures alone aren't going to adequately control the pain. But yet, our EMS providers are operating in an environment where they were essentially, if you think about it, set up from time zero with inadequate resources at the time of dispatch. And so then that sets the tone and really contributes, I think, to the culture of undertreating pain in geriatric hip fractures.
And I think I would add to that is that it's like Dr. Farney said, it's multifactorial, and it's not something that we could just point one finger to one cause. And it, depending on the agency, depends on the factors. So I think you're kind of leaning towards that cultural aspect. I would agree that is definitely a portion of it. But there's a lot more to it. And I think just that looking at the data is the start to any project, and small PDSA cycles will get us closer, right?
So, Aaron alluded to it, because when we started thinking about how do we improve pain management for particularly older adults, which is this population that we were undertreating, who had known in the literature significant consequences of untreated pain, we ended up focusing specifically on the isolated geriatric hip fracture. And I'm going to admit that as a medical director, I didn't even realize this was a problem until we looked at our system data, because I was reviewing charts where the patient actually got a controlled substance. So I thought we were like rocking it in terms of geriatric hip fracture management, because I was seeing only the patients who got treated. But when I looked at the denominator of patients who had severe pain and hip pain and a ground level fall, which I think probably Tony and Aaron will agree with me, that if you're over the age of 65, you fell down and your hip hurts and you can't get up, the probability that your x-ray is going to be negative is extraordinarily low. And if your x-ray is negative, your CT is probably positive for a pelvic fracture of some kind. these patients, for all logistical purposes, like the majority of them are actually going to have a verified fracture on X-ray. One of the things that we have in our region are these things called care bundles, which is really kind of a set of quality measures that all look at different aspects of care. And they've been really useful to us in terms of setting what the expectations of what good looks like out there for our entire region. And so we put out through this pain collaborative, which is our quality improvement collaborative around pain management, the suspected isolated geriatric hip fracture care bundle that included a bunch of things like pain being assessed prior to movement, that the pain score was being used to guide management, and that we request ALS if possible, if it's initial BLS response, speaking with what Aaron was speaking to, which is that many of these are actually initially a double BLS response. We're gonna talk about this. I'm gonna turn over to Tony when we get to our algorithm, but age-adjusted opioid analgesia, which is the idea that we give them a rapid onset analgesia to facilitate movement, acetaminophen for multimodal analgesia afterwards, transport and position of comfort, appropriate monitoring, and then reassessment. That's the components of our care bundle with some of the evidence behind it. But essentially what we developed was a clinical care pathway. Because I think when you talk about pain management, it's like, how do I manage the pain from a rib fracture? How do I manage the pain from an ankle fracture? How you manage those things is a little bit different based on what the particular injury is, right? Some things are amenable to splinting and ice pack. Some of them, as Aaron alluded to, like a femur fracture, are really not. So the algorithm is a low acuity fall with a suspected isolated hip injury, which is usually a hip fracture, that they assess the pain on a 1 to 10 scale. And when I teach this, because I'm so honed into using the pain scale as a trigger to treat, I ask patients, really, I guess it's a 0 to 10 scale, but like your pain on a scale of 0 to 10, where 0 is no pain, 10 is the worst you can imagine, and 7 means that you need something for your pain right now. Because when you think about what it means to have severe pain, it really means I want something for my pain right now. And this is actually similar to some of the language of how you guide children through choosing what's appropriate on a Wong-Baker-Faces scale, but I think applies to all patients. You move them into a position of comfort. If the pain is greater than or equal to 7, if it's a BLS, they should be calling for ALS and seeing if it's available. And we'll talk about this. Like, what do you do if ALS is not available? Like, how do you set the goals in your system? But they should be calling. These are not major trauma patients where I need to have a scene time of less than 10 minutes, right? Like, these are patients where pain management is honestly like the core of what we're doing for them, as well as like evaluating for why they fell in the first place. And if it's greater than or equal to 7, the fentanyl dosing is 0.5 to 1 mic per kilo, and then initiate transport, and then acetaminophen, which in our system is mostly IV acetaminophen, although BLS, we're getting oral acetaminophen very closely as the New York State protocols have been getting updated. If it's less than 7, you start packaging them, and if they start saying it really hurts, then you end up doing the pathway. And this is a pathway that we developed and we tested. We had a bunch of EMTs and paramedics at different systems test this pathway and say, does it make sense? Does it work? Before we did a broader implementation. And when we put it out there, it did make sense and it worked. And we've seen improvement in pain management. But I think it's worthwhile in kind of going through some of this and explaining the why of it. So one of the things I want to hone in on is that the fentanyl dosing in New York State protocols, or in most cases, the therapeutic dosing is 1 to 1.5 mics per kilo for fentanyl by all routes. And specifically, I actually sent this to Tony for feedback, and Tony was like, I think the fentanyl dosing is a little hot. And I was like, I kind of agree with you that the fentanyl dosing is a little hot. And I talked to Aaron, and Aaron's like, yeah, the fentanyl dosing is a little hot. And the reality is, in the protocols, there is no geriatric consideration for opioid dosing, right? Which is somewhat problematic. So I'm going to turn it over to Tony to talk a little bit about the pharmacology and why we might want to dose things differently in geriatric patients.
Sure. Look, appropriate dosing for older adults of opiate pain medications can be difficult. My wife was a diver, so maybe one way to say it is that it's pain management with a higher degree of difficulty. Older adults metabolize opiates differently, just as you said, due to changes in pharmacokinetics and changes to pharmacodynamics, if you like big words. And they also are probably already taking a lot of medications, what we call polypharmacy, and they may have multi-morbidity. As a result, the dose that you routinely give to a younger patient may be too much. And I think that's the first place to start. This dose has a much higher risk of an adverse event, including bradypnea and hypoxia, and even delirium. So, ironically, we were just talking that no pain medication may lead to delirium, but so might too much medication. So it is in some ways pain medication or pain management with a higher degree of difficulty. An optimal approach, which is sort of advocated for as a mantra by geriatricians for frankly managing all medications, is start low and go slow. In fact, as you mentioned, Maya, even though unfortunately national EMS guidelines recommend opioid analgesia for prehospital management at the same dose for all patients of all adult ages, they don't provide any age-specific guidance, and that's a potentially dangerous admission. Older adults may have an outsized reaction to opiate pain control, one that might lead to an adverse event that you might see, bradypnea or hypoxia, or an adverse event that might happen after you transition care, such as delirium. Also, we are in danger of not giving enough pen medication because oligoanalgesia, which is essentially too little pain control, is also potentially going to cause delirium. So it's great that you've protocolized the dose, but I think that the best way to think of analgesia in an older adult with acute pain, particularly after a hip fracture, is first, start low and go slow. That's the piece with an initial dose, but don't stop until you're done. Keep reassessing the patient and assess both whether the pain medication that you've given has caused them to be sleepier, and maybe that's something that you want to keep a close eye on, but also has the pain medication managed their pain? Also, and you mentioned this, Maya, but not all pain control is opiates, particularly for older adults. The Tylenol that you're advocating from an IV perspective um, as part of your protocol may have a very substantial synergistic effect. And keep in mind, pillows, padding, ice pack, position of comfort, it's something that's on the list for all the things that we do, but if done carefully, can really have an impact on pain. I want to also talk briefly, though, about two other real challenges in pain control for older adults. The first is, please avoid using benzodiazepines or other sedatives such as antipsychotics or antihistamines with opioid analgesics whenever possible with older adults. I recognize that many EMS protocols have benzos as first line for agitation management, but these medications are very likely to cause delirium. And as we've been discussing, delirium has a mortality over 1 year of 10 to 26%. It's like sepsis or acute myocardial infarction, and we're trying to avoid delirium. Ideally, benzos should probably be avoided for older adults under almost all circumstances. But if opiate pain control is needed, EMS clinicians should not use these sedatives, particularly probably midazolam based on the literature, unless absolutely necessary. And the other thing that I wanted to bring up, because I think it's really important, is that I couldn't agree more. And Maya, I really liked your approach of, hey, 7 is the number where you need pain medication now, because that's a really important thing. We need to be asking people about severe pain, and we need to be treating severe pain. But many older adults, such as those with advanced dementia, aren't able to communicate their pain level. And that's important to keep in mind because more than 20% of older adults with hip fractures, the folks that we're talking about, have dementia. And so it's unsurprising, but important to emphasize that older adults with dementia are much less likely to receive pain control than other older adults. And so while this might be a little bit difficult to assess at a quality level, it's really important for an individual EMS clinician to say, hey, even though this person has dementia, I want to assess if they have pain and I want to treat their pain if it's severe. And so I'll give you a couple of thoughts about how to assess pain in older adults with dementia. The first is, no big surprise, even folks with moderate dementia can provide useful information if you ask them. You might not want to use a numeric scale. You might want to use simpler approaches. Are you hurting anywhere? Does anything hurt now? Show me where it hurts. You may want to use the faces scale or take an approach similar to you take with children. Try to speak slowly and calmly, maintain eye contact, and ask one question at a time. But realistically, look, we're going to be caring for a lot of patients who can't speak or who won't be able to respond. But please, look for nonverbal indicators. Pain in dementia is often expressed with changes in behavior, facial grimacing, guarding, moaning, increased breathing effort, rigidity, resistance to movement, withdrawal, aggression, agitation. All these things, particularly a sudden change from baseline behavior, is particularly important. For folks who like tools, there's something called the pain ad, the pain assessment in advanced dementia. And again, maybe not as a tool, but perhaps as a mantra. Breathing, vocalization, facial expression, body language, and consolability. If you think about those 5 factors, always keep in mind that occult pain might be in the differential. We're talking now about older adults who present after a fall with isolated hip trauma. But what we really often get called to are nursing home agitated patient. And we don't get a history of a fall, and we don't get a history of hip pain, and the older adult has dementia. So I wanted also to emphasize that while this protocol is critical, also when you're called to a nursing home because a patient with advanced dementia is agitated and aggressive, remember to consider whether that behavior change might be caused by pain, because that's not something that you're always going to hear. And when you're at the patient's bedside, you can also ask the caregiver because they may have collateral information. Does this behavior new? How does this patient behave when they're in pain? What's different today? These kind of approaches, I think, are really important because it's easy if a patient can't respond to us to not think about pain and to not think about the importance of managing pain, but it is no less important and it is going to be no less impactful. In fact, older adults with dementia are more likely to get delirium. And so the impact of pain control is likely even more significant in the EMS context for these patients.
Talking about the pharmacology, and I agree completely, and I think that's one population where we don't assess pain and we often don't treat the pain. A lot of the components of the scale that you're describing are actually similar to a scale that we use in children called the FLAC, right? Which looks at grimace and rigidity and consolability. It's actually very similar. And I think while that's not the exact tool, and you can't document the tool that you spoke about in most PCRs, I think you can actually calculate some of those things or look for improvement in those indicators when you treat pain. One of the reasons we thought it was really important to have multimodal analgesia here is specifically because I think multimodal analgesia is one way that you reduce the side effects of any one medication. And in a population of patients that's really susceptible to side effects, I think that's really important. There are guidelines in the UK and the NHS for how you manage acute pain from hip fractures, and time to acetaminophen is a quality measure. And in the post-op hip fractures where I work, they manage their pain with IV acetaminophen, and then a lot of them don't even end up needing opioids because they're getting scheduled IV acetaminophen, and then if they have unrelieved pain after that, then they get opioids. The reason we have opioids up front is because I'm not going to sit there with the patient on the floor for 10 minutes infusing Tylenol and then waiting another 10 minutes till it's been active. Like, I need a rapid onset medication.
Couldn't agree more. And I was going to emphasize that in some ways, we think of multimodal analgesia as opioid sparing. And that's how we think about it. And that's, I think, how we should think about it. But just to emphasize what you said earlier, I really think it's important to get multimodal analgesia on board quickly. We know that these are patients who are at very high risk for side effects because their liver function, their kidney function is just different than a younger patient. And so pharmacokinetically, there are going to be impacts, but ultimately that shouldn't prevent us from giving a dose, and that shouldn't prevent us from giving other medications, and that shouldn't prevent us from reassessing pain and considering a second dose if we haven't controlled their pain yet.
Aaron, I'd like to hear a little bit more from you, because when we put this out for public comment in our region, there was a lot of discussion about emphasizing really the ALS aspects, particularly in rural systems who might have limited ALS. And so I'm interested in your perspective as a medical director who particularly specializes in rural systems. Like, how do you set the goals for a system and how do you design in a system that might have limited availability of ALS for something like this?
I appreciate that. That's a really good question. I first really just want to compliment what Dr. Rosen said. That was incredibly well said and spoke to a lot of the foundation of the discussion we're having today. And so it starts there. It starts with that discussion. I think historically, folks have been reluctant to administer opioid analgesia in an elderly patient with dementia over the concerns that we're going to potentially worsen their confusion or harm them. Understanding that also doing nothing or doing oligo analgesia, like some but not enough, can also be harmful. So that's the great, if this job was easy, anyone could do it, right? So the hard part of this job, of what we do out in the field or in the emergency department taking care of these patients, is realizing there is no perfect option here. Everything we do carries some side effects, but ultimate or potential for those. Ultimately, what is the best path forward? And the consensus, I think, in this group and more broadly, is let's treat pain, particularly acute pain, particularly in vulnerable populations such as geriatric patients with dementia who may not be able to communicate that they would like some pain medicine for their broken hip. And so once we've kind of sat down with the key stakeholders, agency leadership, clinical leadership, and come to terms with that, then it becomes, that's the standard. That's what we want to meet. How do we get it done? Yes, it's potentially going to have some operational implications. Yes, I don't know of any system out there right now that is so flush with paramedics that they don't know what to do with them. If they're out there, please send them our way. There aren't enough out there, right? And that, this is not a podcast about why that is, but that's just one of the realities that we operate in. And so it's not lost on myself or any of the other medical directors when we start talking about, listen, we need to try to be doing more for this patient population and doing stuff that really only ALS can do, like IV opioid administration. That's another thing that we're kind of pushing, a somewhat limited resource. And then that becomes even more pronounced when you start talking about the spatial geography relationships out in a rural environment. In an urban environment, you may have a dozen paramedics covering a small condensed city. In a rural environment like some of the ones that I work and operate in, you may have one paramedic covering 640 square miles at any given time. And how do you leverage that? But again, one, it's establishing that this is the agreed upon standard, and then getting buy-in from those BLS units that are the ones primarily being dispatched on these. And so I've sat down and had one-on-one discussions, both in writing, via email, phone, text, in person, with a lot of these stakeholders who had some concerns. Do we wait on scene for an hour for a paramedic to come from Rochester down here if there isn't one? And the answer is, of course not. Nothing in this protocol says, or it's not really a protocol, but a care bundle says, thou shalt wait on scene for an infinite amount of time until a paramedic from Dr. Rosen's, from down in New York City shows up and helps you. You know, we operate in reality confines. So if you look at the algorithm, if there is no ALS available, then we do the best we can, standard care, and move on. But the change is try. Just try. And you never know who's out there lurking, available, until you ask for help. And so and I suspect in most systems, most of our geriatric hip fractures, they're not going to the major trauma center. That's probably not the best place for those patients. They don't need to be in that sort of hectic, chaotic environment. They need a nice, quiet atmosphere where they can get their hip fixed, heal, and move on. And so a lot of times that's your local community hospitals. And if there's ALS between there and where the patient is, then hopefully we can engage them to help. If not, and ALS is coming from a distance, then that's something that system leadership needs to sit down at the table and say, that's a problem not just for this patient population, but any patient in which a paramedic could be needed in that corridor, right? And so establishing the standard is paramount to then sort of defining where do we need to improve the system.
Kevin, you got thoughts?
Lack of ALS is a contributing factor. And the part of our care bundle and the message that we're trying to present to the folks in our region isn't necessarily that everybody needs an opiate, right? There's so many other steps before we get to that, and emphasizing those two, hopefully, as part of our PDSA cycles, are going to make the incremental changes that then build on each other.
One of the things as I look through the data that I review every single week to say, are we making a difference as this spreads through the agencies in our region, is one of the greatest differences is that we are getting more acetaminophen administrations in old people who fell down than ever before. And we've actually, while our numbers are certainly not something to write a home about just yet, we have improved overall by 10% across all patients in our region pre-hospital pain management for old people who fall down and have severe pain. And so that's not where we're stopping. That's just the beginning. And every time I see one of those, right, like I feel just like incredible satisfaction that we're headed in the right direction, because every single one of those is an actual patient, right, who had a better of experience of care. But even more than that, if you think about if there's any impact on delirium, if there's any impact on some of these cardiovascular outcomes, if there's any impact on that, if you can impact the whole system, that's a tremendous difference, because I derive great satisfaction around what we did around pre-hospital drug-assisted airway management, but that's like 5 patients a month. This is hundreds of patients per month in our system of like old people with severe pain who fall down. Recently, so I'm the medical director for our local paramedic program, which is nice because when we do regional quality improvement, this has actually been a simulation scenario in our paramedic program for a while. I have a day, because I'm obsessed with old people who present as falls, I have a day where every call for their simulation is dispatched as a geriatric fall. And the outcomes are all sorts of different, but one of them is always been a hip fracture, where the objective is to manage the pain as soon as possible and give kind of good pain control, and multimodal analgesia has been added to that. But this year, because we were actively doing this quality improvement project, I kind of like saw it with a new light, right? Like I facilitated this this scenario. And I had a wonderful paramedic put on her jerry wig and wedge herself next to the toilet, right, as these often present, and then watch paramedic students who are going to be the next generation of paramedics in our system, like work through this scenario and kind of make the decisions around it. And what dawned on me as we went through this, right, and everybody had a little bit of opportunity for improvement, and there were so many really nice things that I saw, is that this is something where we know what excellent looks like. It's like this definable thing, right? Which is compassionate communication, a thorough assessment to figure out what happened or make sure it's not a stroke and a hip fracture. Think about, how do I communicate with that patient, position them well, kind of do the spatial logistics of treating pain before moving, getting this patient out with minimal movement, starting the IV acetaminophen, having a good destination decision, which very often we're like emphasizing, right? Get them to the tertiary care center, but like having a discussion is like, maybe this patient should go to the Geri ED, where they'll take really good care of their hip fracture. And it is kind of this epitome of all these things are really good. It's like compassionate patient communication, timing of interventions, tailoring pharmacology to the patient, thinking about appropriate destination, and like patient reassessment, all in a single scenario. And I think people don't think about, much like many of the things that I love about EMS, like people don't think of those as kind of like high end, like really, this is what excellent clinical care looks like scenarios, right? Like we tend to think about the anaphylaxis that was managed or something. But I looked at this and I was like, this has, like, if you do this really well, this has like a little bit of all of that all together in one. And there's really what good looks like. And the good news is that you don't have to wait very long between cases to practice truly excellent care, right? Like you have an opportunity to do that. So as part of this quality improvement project, right, I started doing feedback forms at my agency. And it feels really good to give feedback that is recognizing all the little things put together of what good looks like for cases that I think nobody was really, I certainly, as a medical director, wasn't paying attention to before. And I hope that like focusing, and I'm seeing a signal in the data that focusing on this one population, because I think it's a little easier for people to exercise their compassion muscle for Grammy. I hope that that spreads to all the patients and sort of like valuing these particular types of interactions. So we're at about an hour, so we should be finishing up. I was hoping to kind of give you all a minute to kind of give, like, if you had one take home to somebody listening, really of something that they could incorporate into their practice tomorrow, what would it be?
I can start. So I would just say that this is, particularly with geriatric hip fractures, this is a pathology that most of us have luckily not experienced, right? This is a pathology of typically older folks. And hopefully by the time I get to that population, I'm still not out running calls. But so most of us out there taking care of these folks have never had the misfortune of having had a geriatric hip fracture. So I think just having a little metacognition and self-awareness that this is not something we've been through or can necessarily relate. And then also remembering old people are tough. They don't complain. They've been through a lot in their life, most of them anyways. And they're just kind of happy that you're taking them to the hospital and they don't want to ask too much. And keep those things in mind as we think, well, they don't seem that uncomfortable. Ask them, would you like some pain medicine? That's usually the simplest question. Would you like some pain medicine? And the answer is almost always yes.
I couldn't agree more. Thanks for inviting me. And I want to commend all of you and your team for this really wonderful new care bundle that I think is going to have a huge impact on the older adults for whom you care. And I think that my final thought would be just to echo what everyone has said, which is I think that as an EMS clinician, when you arrive at the door and recognize the call is for a hip fracture, you don't necessarily think this is a call on which I can have a huge impact. This is a patient where if I take the optimal approach, I can really help this patient. But if I don't, that can also have an impact. And I think that taking away that these are patients who, as you said, Maya, you're going to see them every day. These are patients for whom taking a real optimal approach can really impact the trajectory of their care. You have a real opportunity to help these patients, and hopefully, it's an opportunity that EMS folks are excited.
I think for my final thought, we've done a lot of talk about the clinical aspect, and part of what I appreciate what Maya had to say about me is my focus on compassion. I think I kind of want to leave with that is and echo something that Dr. Farney said is like the just try aspect of it. And I'm not a fan of platitudes, so if somebody were to say to me, "How do I incorporate compassion into what I'm doing?" The generic answer is treat somebody like family, but I hesitate to say that because not all of us have great families, right? Like, so what I would say is if you were looking at a patient and trying to build up compassion for this patient, treat that patient as if it was Dr. Dorsett's family or somebody that you do care about's family. And I would expect, you know, excellent care if you came to take care of my mom, just like you would want that for me to take care of your mom. So look at this patient as a colleague's family member, and you would want to do everything for them. And that feeling that you get for caring for another person is that compassion muscle that you're exercising.
There's great benefit for you. There's a great book called Compassionomics that looks at the benefits to our psychology and the benefits for us. So that's a wrap on this episode. I hope everyone's at least a little bit inspired to look at opportunities for pain management in geriatric patients with a little bit of a new light and understanding the impact that you have downstream. Thank you very much to all of you for taking the time and look forward to the next episode. Thanks all.
Thanks for having us.
Thanks for having us.